Fatima Rodriguez and Mike Gibson joining you talking about atherosclerosis. Talk to us a little bit about why we should care.
Thanks so much, Mike. So, atherosclerosis is the leading cause of death worldwide, and it's really an insidious, progressive disease that starts early in the life course. And fortunately, we have a lot of great tools to prevent it.
Now, I'm a plumber. I fix blockages. Talk to us, though, about the different kinds of blockages and not just how narrow they are, but what makes up the stuff in those blockages.
That's right. I think increasingly we know that plaque is more complex than just obstruction. There's been historically this obsession with stenosis, as you know, being an interventional cardiologist, but we know it's much more complicated than that. There are different kinds of plaque. There's stable plaque, and that plaque tends to be more calcified, and that which we often see with chronic coronary disease. But the plaque that we really worry about, that you see, in the cath lab when people have events, is soft plaque, low attenuation plaque that's vulnerable, that has a thin fibrous plaque, and that's really what we're trying to identify early before it causes problems.
Now, for our audience out there, what are the kinds of things they can do to minimize that soft plaque?
Great question. So there's a lot of things that we can do that are modifiable risk factors for heart disease. There's things like having, your cholesterol under check, lower your blood pressure, not smoking, exercising, eating well, particularly with a focus on weight loss. But then there are things that are non-modifiable. We know that age is a very strong predictor of risk. We know that men are, especially older men, are at higher risk of having particularly obstructive plaque, and then genetic predisposition for disease. So really understanding your risk factors, and we'll talk a little bit about this, but not just knowing your numbers, but for some people actually understanding, do you have plaque? And should that modify the way you're being treated?
Now, there's an old school way of looking to see if you have plaque, like I do, looking at an angiogram. What are some of the tools we use in the cath lab to look at that plaque?
Right. So there's the traditional way to look at plaque is really to do an angiogram. And again, that's in the setting of a acute coronary syndrome. That is the gold standard, what you should be done. But now there's a lot of more detailed tools that are actually non-invasive. And in my practice as a preventive cardiologist, I often rely on non-invasive tests like CT scans to look at plaque. The simplest way to look at plaque is a coronary artery calcium scan, and that tells us the amount of calcified plaque, which again correlates pretty well with low attenuation plaque as well, and as a risk factor can help us decide on treatments. But now there's increasingly more focus on looking at plaque with contrast, so with CT angiography, and then using advanced tools to analyze the plaque. So it's not just the obstruction, but what kind of plaque? Is it low attenuation plaque, soft plaque, total plaque burden? And the future of prevention is really to use that information to guide preventive treatments.
Do we have any tools to look not just at how much plaque there is, but what's inside of it? Other than that, do we have tools to look at inflammation, things like PET scanning and things like that?
That's right. So that's an emerging subject, and in terms of not just looking at the attenuation of the plaque, but is there perivascular fat? And there's increasing interest in looking at this with tools like PET scans. I would say that at least in my clinical practice, it's not something that we use ready for prime time, but it's certainly something that we're interested in the research area.
So how do you use imaging in your clinical practice? I'll be honest, I wanted to work out. I had a calcium score that was very, very, very high, and that triggered a cascade of events. Are you using it as a screening tool, or are you using it in people who you know have the disease, or both?
So I use imaging increasingly in my practice, and I think we've learned over time that relying on just fit factors like LDL cholesterol, which we know is an important risk factor and is strongly correlated with disease, may miss some people that already have plaque. Something that I actually start with is a little simpler than that. I tend to look at existing studies that people have had to look at incidental coronary calcification or calcification in other vessels, and really use that as a way to guide risk discussions with my patients. So if they have evidence of plaque incidentally, great. We use that as a way to kind of reduce risk. If not, my first step is usually a coronary artery calcium scan, which is very helpful, particularly in individuals over 40 with existing risk. And for symptomatic patients, a coronary CT is very helpful. I think in terms of prime time, we don't tend to use it in primary prevention yet. And there are studies underway to determine, is it helpful to guide management beyond understanding calcified plaque, but also looking at non-calcified plaque.
I think that'll be important. I mean, I wanted to work out, so we got a calcium scan. It was very high. That then triggered some questions on our part. My LDL was 70. I mean, I was on a statin and ezetimibe, so why was it 70? So then we looked at my LP little a, and that was very, very high, which changed how I was treated. So, at least for me as a patient, getting that knowledge did change how I was treated. Now, you were part of a study called Confirm 2. Talk to us a little bit about the learnings there and specifically what you learned about gender in that study.
So confirmed to it is a large registry of individuals that had indications to undergo CCTA, so a coronary CT scan. And we try to understand the plaque differences among men and women in this particular study. And we used AI to quantify and characterize the plaque. And what we found is that although, as has been shown in many studies, women tend to have lower rates of obstructive disease, when they have low attenuation plaque, it actually is more predictive of events. So this is something that I'm a stickler on in my clinical practice. When the residents or the team says no obstructive disease, I think that's incomplete information, and we know that the vulnerable plaque really matters, and treating that plaque matters. So again, women have very high rates of low attenuation plaque that are presenting.
That's the fatty plaque, right?
That's right. That's the fatty plaque. That's the plaque that may be missed in a coronary artery calcium scan, like the one that you had. And again, that plaque can flick off and cause events. And again, we know that women in general have higher rates of events that are due to non-obstructive disease. So it's not about obstruction. It's really about the biology of the plaque. And we really need to pay attention. And again, we know that heart disease is underdiagnosed in women. So when they have these imaging tests, it's really important to look at them in detail. And I really think that the future is around AI quantification, because a lot of these processes used to be very cumbersome for people to have to do manually. And what AI can help us do is make it reproducible, make it much faster. And then for people who have repeat scans, we can actually track changes over time. Is that therapy working for you? And can we not just see plaque progression, but ideally plaque regression? And that's something that we cannot do with coronary artery calcium scans.
Well, Fatima, thank you for sharing all your valuable knowledge today and how you're practicing. Thanks for joining us.
Thanks so much, Mike.